And we are live on YouTube right now.
Very good, excellent. So I can see that people coming. It's 9 o'clock already. So, Bismillah wa salatu wa salam ala Rasulullah. Good evening, everybody. Welcome to our Saudi and Urology group webinar. We're very lucky today to have Professor Schlegel with us. We've been following his steps before, and we've been following his papers, and he inspired all of us for the microTESE. So since last time that he was at King Faisal 2006, we're very lucky to have him today in our webinar. So welcome, Professor Schlegel. I'll leave the mic to Dr. Abdul Malik Mirdawi, to the chairman of the session. And welcome, Dr. Saad Abu Mulha. Welcome, Dr. Abdul Majid Beiti. Thank you for accepting the invitation to moderate the session. And please, Dr. Abdul Malik.
Yes, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good evening, everybody. I'm Dr. Abdul Malik Mirdawi, consultant urologist and urologist male infertility in Prince Sultan Military Medical City. On behalf of our Saudi Andrology group, I would like to start our webinar subjected as does empiric medical therapy work for male infertility. Our guest speaker tonight is Professor Peter Schlegel. He's urologist in chief at Weill Cornell Medicine in New York. As we know, Prof. Schlegel is a well-known name in andrology and male infertility with hundreds of publications, which most of them are landmarks in era of infertility. With high volume of sperm retrieval rate by microTESE in the world. As we know, a lot of our Saudi patients went there to Prof. Schlegel as a most expert in microTESE. Also, I would like to welcome our Saudi Andrology Group Chairman, Prof. Naif Al-Haddal. He's a professor and consultant urologist and andrologist at King Faisal Specialist Hospital. And our moderators, Dr. Saad Abu Mulha, consultant urologist and andrologist at King Abdulaziz Medical City National Guard Hospital. And Dr. Abdul Majid Beiti, consultant urologist and andrologist at Prince Sultan Military Medical City. With special thanks to Ferring Company for sponsoring this webinar. Dear attendees, you can type your question and we'll try our best to ask Prof. Schlegel as much as we can at the end of the session. Mic for you, Prof. Schlegel.
Thank you, Dr. Mardawi. Thank you for the opportunity to speak here today. It's a pleasure to be back in the kingdom, even if it is only virtually back in the kingdom, to share some of information and some of our views of our approach to treatment of patients. I think this is of great value. You obviously see a large number of patients in Saudi Arabia, and we're blessed to have the opportunity to help treat some of those patients. So the topic was to address medical therapy, but I will briefly give an update on microTESE and the management of non-obstructive azoospermia as part of that talk. In terms of conflicts of interest, financial relationships, I am supported by the National Institutes of Health Research Organization in the United States. I have consulted for a number of other groups, including Gilead, Roman Health, and of course, Ferring is supporting this presentation. Also had leadership positions with ASRM as immediate past president of that reproductive medicine society. And I'm currently the chair for the Male Infertility Practice Guideline, which is nearing completion by the American Urological Association and ASRM as a joint venture. In terms of male infertility, I think there are limited options for treatment at this point. That makes it challenging. An obvious question is there a pill, is there medical therapy that a patient can take? And certainly all of our patients ask us this type of question. So I'm going to break up that discussion into treatment of men with low serum testosterone and take the broader question of what medications may be used for idiopathic male infertility. Idiopathic, by definition, of course, means men with normal hormones, normal testosterone, and no other treatable condition. I'm going to talk about SERMs, or selective estrogen receptor modulators. I'm going to talk about the use of aromatase inhibitors. I'm going to talk about antioxidants very briefly. I'm going to talk about FSH as an injection therapy. I'm also going to talk about treatment for men with non-obstructive azoospermia with medications. And then I'm going to talk about microTESE as a treatment for non-obstructive azoospermia as well. So the overview of my presentation is that I'm going to talk about the rationale for medical treatment of male infertility, the agents used with the advantages, disadvantages, and potential risks of each. I'm going to present a literature search of randomized controlled trials. I'm going to talk about perspective on the effects or benefits of these data search results, give my personal view on use of the agents and personal experience, and again, give a brief update on management of non-obstructive azoospermia, and then take any questions or discuss cases thereafter. So when we talk about men with a low testosterone level, we're typically talking about men who have had a total serum testosterone, which should be measured in the morning, and it should be repeated, and if low, followed up with LH and prolactin levels if indicated. Testosterone replacement, that is giving exogenous testosterone to a man who's interested in fertility, is clearly not appropriate for men because it suppresses LH and FSH production. And in general, it stops sperm production, although some of the intranasal or shorter acting testosterone agents may have less adverse effects on fertility. Still, in general, exogenous testosterone is best avoided because it can suppress fertility. Now, co-treatment of men with testosterone as well as HCG can continue internal production of testosterone and can salvage fertility for some men who cannot come off of their androgens or testosterone treatment. It is preferred to never use exogenous testosterone where possible, but again, in the rare cases where we can't stop testosterone for systemic effects, co-treatment with HCG injections as well as testosterone can provide some fertility potential. The most commonly used agents in published literature include clomiphene citrate, typically given as 25 milligrams or half a pill per day, clomiphene citrate 50 milligrams every other day or in other frequencies of treatment, tamoxifen, typically as 10 or 20 milligrams per day, HCG, typically given as an injection of 1,500 to 2,500 international units twice a week, and aromatase inhibitors, including anastrozole and letrozole, have been published, and there are newer agents such as leflutrozole, which is now being explored as a potential agent, and some data has been presented, at least in abstract form, on this agent. So how do these interventions work? Well, we know that high intratesticular testosterone is important for spermatogenesis. We know that that is typically driven by the pituitary and gonadotropins. The body in males detects testosterone both as testosterone and circulating estrogens. And actually, the pituitary is particularly sensitive to the effect of estrogens. So if you decrease estrogens, pituitary senses that testosterone is low and produces more LH and FSH. So impaired sperm production associating with low circulating testosterone may reflect inadequate intratesticular testosterone levels. That may be decreased testosterone production, or it can be increased conversion of testosterone to estrogen, which usually is detected on blood tests as a low testosterone to estradiol ratio. Clomiphene, anastrozole, and HCG or FSH can all act in this axis potentially to stimulate the testicle to work more productively. Clomiphene citrate as a selective estrogen receptor modulator is actually a mixed racemic compound with both zooclomiphene and N-clomiphene. It prevents the pituitary from sensing circulating estrogen level because it blocks those receptors and results in increased LH and FSH production, again, primarily at the level of the pituitary. That results in both increased testosterone production and stimulation of Sertoli cells. It also results in some increase in estradiol from the conversion of testosterone through aromatase to estradiol. It is both a mixed estrogen receptor agonist and antagonist, and therefore increased estrogen levels may not be acting on the body. Even though you have an increased estrogen level when a man is on clomiphene citrate, that may not be a bad thing. You may actually have blocked the effect of that estrogen by the clomiphene citrate treatment itself. So if we look at what happens with clomiphene or tamoxifen, we are blocking the estrogen action, both at the level of pituitary and the hypothalamus. Primarily action is at the pituitary level. That results in an increased LH, increased FSH, subsequent increase in testosterone production. Now, HCG injections are actually a direct stimulation of Leydig cells in the testis. They result in increased testosterone production, and it does not require response of the pituitary to the drug. That's a potential advantage of HCG injections. It is well known that HCG is highly effective for hypogonadotropic hypogonadism, including Kallmann syndrome. And again, as discussed previously, for men who are on exogenous testosterone but cannot stop that treatment. It certainly has also been used in men with non-obstructive azoospermia. And I would interpret that the HCG use in non-obstructive azoospermia has mixed effects. Yes, it often results in increased testosterone production, but because of that higher testosterone, you actually suppress FSH production. And I would argue that the decrease in FSH that results from HCG treatment may actually be an adverse effect. It may decrease the potential for sperm production. HCG again acts directly on the Leydig cells, resulting in increased testosterone production. But again, the downside is the decrease in FSH that regularly occurs, sometimes FSH being suppressed to undetectable levels for men who are receiving HCG. Therefore, we rarely use HCG as a monotherapy, particularly for men with non-obstructive azoospermia. We certainly use it routinely for men with Kallmann syndrome or other forms of hypogonadotropic hypogonadism. Aromatase inhibitors function by blocking the aromatase enzyme, which of course converts testosterone to estrogen, and that inhibits estrogen production. The decreased estrogen levels result in pituitary LH production. Increased LH and FSH affects more testicular testosterone productions. It is important to remember that estrogens do have some physiologic effects. For example, they're involved with fluid reabsorption in the epididymis, and estrogens also regulate male libido. So excess suppression of estrogens may cause impaired libido in some of the men that we treat. It's also concerning that some of the aromatase inhibitors have tachyphylaxis, and therefore the benefit of an aromatase inhibitor may wear off, at least for anastrozole, after 2 or 3 months. So again, if you give an aromatase inhibitor, you are blocking the production of testosterone, so testosterone is no longer converted from testosterone to estrogen. That lower estrogen results in more production of LH and FSH at the pituitary level, subsequently higher testosterone levels, higher FSH levels. This is the results of an experiment that was published a number of years ago. It actually involved treatment of elderly men, but it parallels my personal experience in treating men with aromatase inhibitor anastrozole over a period of time. What you can see, and this is actually 3 different treatment regimens. This is placebo treatment. This is treatment with 0.5 milligrams per day. This is treatment with 1 milligram per day. Testosterone levels increase nicely in these elderly men who receive medication, but that benefit drops off at 2 months and at 3 months, again, demonstrating the tachyphylaxis that I mentioned before with this agent. So low serum testosterone can be both low production and excess metabolism or conversion of testosterone to estradiol. That testosterone to estradiol is aromatization. It can be measured by testosterone to estradiol ratios, and low TE ratios are seen in elderly men, in men with testicular failure and infertility, and it is predominantly or most markedly seen in men who have Klinefelter syndrome. Most men, if you use testosterone in nanograms per deciliter and estradiol in picograms per ml, most men have a TE ratio greater than 10. That is less than 10, meaning about 7 for men overall with testicular failure and severe infertility, and about 4 for men with Klinefelter syndrome. And this is just a graphical representation. If you take that cut point of 10 here, you can see that fertile men have an average TE ratio of 16. Patients with testicular failure have an average TE ratio of 7. And again, that TE ratio is 4 if we just look at men with Klinefelter syndrome. Sometimes people say, well, is that aromatization occurring just in fat? Is it related to obesity? We actually find that the testosterone to estradiol conversion occurs primarily in the testicle. So it is important for function of the testicle. Leydig cells are clearly the primary source of aromatase. When you give HCG, you may increase the aromatase activity, but the physical arrangement of Leydig cells that we see in infertile men or elderly men, where the Leydig cells are clumping together, it's very similar to what we see in Leydig cell tumors, and it often results in this increased conversion of testosterone to estrogen. Remember, of course, many men with Leydig cell tumors present with feminizing symptoms rather than just an increase in testosterone production from an increased number of Leydig cells. Again, we've talked about the physiologic role of estrogens in reabsorption of fluid. If you take a rodent, which has very high levels of sperm production, and you knock out the estradiol activity, you'll actually see adverse effects, swelling of the testicle from too much fluid being present in the testicle. So there are some potential adverse effects of excess estrogen. Response to aromatase inhibitors may be limited by that, and we certainly see excess estrogen in prostate cancer patients results in fibrosis within the testes. So there's a fine line between how much we can decrease estrogen to increase sperm production, whereas too much of a decrease in estrogen can result in some damage to the male reproductive system. Early studies that we did using a crude aromatase inhibitor called testolactone actually were associated with a substantial increase in total motile sperm count. These are men in blue who are control patients who just had repeat semen analyses. Patients in red were men with low TE ratios who were treated with testolactone and had a substantial increase in total motile sperm count. So some clinical evidence that aromatase inhibitors can benefit sperm production. Similarly, when we look at a series of men comparing their baseline to their semen parameters when they're on anastrozole treatment, we can see substantial increases, particularly in concentration, but also in total motile sperm per ejaculate when they were on that anastrozole treatment. And again, These are patients who have low TE ratios. Of note, the patients with Klinefelter syndrome actually did not respond as well as the men with true idiopathic male infertility and abnormal TE ratios. So some would say that there are limited data on the effectiveness of testosterone enhancing therapies relative to the action of testosterone replacement. In other words, if you have a man with low testosterone, you're trying to increase the testosterone. There aren't a lot of comparisons of, for example, clomiphene citrate to just giving exogenous testosterone, which of course we would not do for an infertile male patient. One study that actually at least looked at this was published by Taylor et al. It looked at the absolute increases in testosterone for men who received clomiphene treatment versus men who received testosterone gel. And you can actually see that the end treatment levels, testosterone 553 versus 572, was actually comparable in both of these treatment groups. This is not a randomized controlled trial, it's just a comparative study, but it does suggest that clomiphene citrate is a reasonable treatment and a potential alternative to exogenous testosterone, not just for infertile men, but potentially for all men with low testosterone. Another concern when you're affecting the action of estrogen, which obviously is important in terms of bone mineral density, is what is going to happen to bone mineral density over time. This is a study from Dr. Mulhall in New York, who showed that the proportion of treated patients receiving clomiphene citrate therapy actually tends to, proportion of patients with osteopenia and osteoporosis tends to decrease over time when men are treated with clomiphene citrate. So again, clomiphene does not carry a significant concern in terms of adversely affecting bone mineral density, even though it has some action on estrogens. So, testosterone enhancing therapies, meaning treatments that help make men produce more testosterone internally, SERMs, aromatase inhibitors, HCG, all increase testosterone levels, all appear to be an alternative to testosterone replacement, and are especially important for infertile men with low serum testosterone levels. Now I'm going to change course somewhat. I'm going to talk about treatment of men with normal serum testosterone. So this is truly men with idiopathic male infertility. Men with low testosterone have an abnormality which we are treating. Men with idiopathic male infertility have normal serum testosterone levels. So theoretically, non-specific stimulation of the testes, whether giving FSH or increasing internal testosterone levels, could enhance sperm production. Randomized controlled trials have been done and allow evidence-based evaluation of the effectiveness of these treatments. Male infertility trials are limited in their ability to evaluate the male and his fertility potential because a male, of course, is only demonstrating his fertility potential through a woman. So it's an indirect measure in the end. If we're trying to give a medication to improve male fertility, we unfortunately have to measure that result in large part in terms of whether the wife gets pregnant, not specifically the male alone. So let's look at the studies of SERMs for idiopathic male infertility. Most of these studies have involved either clomiphene or tamoxifen. These are all systematic, and I'm going to refer to systematic reviews and randomized controlled trials only. There are two systematic reviews that were appropriate and informative. One is published by Canarella, one by Chua et al. They looked at a total of 16 total randomized controlled trials, and they included 1,164 clomiphene, 993 for tamoxifen. If you summarize these results together, they show beneficial effects of SERM treatment on pregnancy rates with an odds ratio of achieving a pregnancy of 3.4. For oligospermic or asthenospermic men, the odds ratio was 2.4 in terms of pregnancy rates. And again, a summary of all of those results showed no significant adverse effects. Increasing your pregnancy rate by 2.4-fold or 3.4-fold sounds like a very substantial increase. And this is certainly shown in this funnel plot where 1.0 would be no effect of the treatment, meaning placebo and treatment had the same pregnancy rate. The studies on clomiphene are in green. Studies on, tamoxifen are in green. Studies on clomiphene 50 milligrams are in red, and the black squares are clomiphene 25 milligrams. And you can see that there is a broad distribution of these studies with efficacy suggested for each of these agents and each of these doses in the many studies. And again, a combined effect in the 2 to 3 range in terms of odds ratios. So I would interpret this as a relatively impressive apparent benefit of treatment with SERMs. So the question becomes, why aren't these agents used more broadly? Should we use them? Well, it's important to look at the actual pregnancy rates for the men with idiopathic infertility. So only 26% of the men who received clomiphene or tamoxifen had natural pregnancies occurring after that treatment. And 9% of the men receiving placebo had their wives get pregnant. If we look just at the CHUA systematic review, which pulls everything together, basically it's an 18% pregnancy rate in the treated group versus 8% for men on placebo. So that means that the vast majority of men that we would treat for idiopathic male infertility using just a SERM, the vast majority are not going to get pregnant, and the difference between placebo treatment and SERM treatment is relatively small. So pregnancy results really only were for a small cohort of treated men. The absolute increase in pregnancy rates is small. The benefits of medical therapy, therefore, are very small when we can compare it to assisted reproductive technologies. Certainly, an increase in sperm concentration and motility was noted in the randomized controlled trials for men with oligospermia and/or asthenospermia, as well as improved sperm morphology. So there is some suggestion that these drugs work to help make better sperm. Unfortunately, the pregnancy outcome benefits remain fairly limited. So let's shift gears somewhat and talk about SERMs for men with non-obstructive azoospermia. And in this setting, we're really talking about medical therapy prior to planned microTESE with assisted reproductive technologies. So this sort of treatment has been proposed or discussed in a number of published papers dating well back into 2005, when Hussein reported that clomiphene restores sperm to the ejaculate in men with non-obstructive azoospermia. It's important to note that the patient populations who are treated were actually those same men who are likely to have sperm in the ejaculate with a repeat semen analysis without any medical treatment, meaning they only reported on men who had late maturation arrest or hypospermatogenesis on biopsy. However, they did report 64% of treated men had sperm return to the ejaculate with 1 to 16 million sperm per cc, quite dramatic results for non-obstructive azoospermia. Unfortunately, it's important to remember most of the studies that quote unquote demonstrate the value of SERMs were actually uncontrolled interventions. It is equally important to remember that if you just take a man with non-obstructive azoospermia and you repeat the semen analysis with an ESP or extended sperm preparation, where the concentrated semen pellet is examined in exquisite detail microscopically, you will find sperm in 5 to 35% of those men. So you've got to be careful looking at the supposed benefit in a treated group when a control or untreated group may have sperm found just with repeated semen analyses. So in terms of SERMs or aromatase inhibitors for men with non-obstructive azoospermia, there are no high-quality data to analyze. There are no randomized controlled trials. Most of the studies are retrospective, non-randomized, or of otherwise questionable study design. Clomiphene has been reported in a prospective non-randomized study of 612 men, HCG in a retrospective study of 83 men. Letrozole is the only one that had a randomized controlled trial of 62 men with results on 52 reported, and FSH had a non-randomized comparative study that was published. Observational studies have evaluated the relationship of medical treatment prior to planned TESE and showed no benefit of pre-treatment. So the largest of these was a retrospective study of 736 men from Cornell who are undergoing microTESE for non-obstructive azoospermia. We looked at the men who had normal testosterone at baseline. They actually had a 56% sperm retrieval rate with no treatment whatsoever, no medical pre-treatment before microTESE. For men with low testosterone who received treatment, their sperm retrieval rate of 51% was actually lower than the men with low testosterone who received no treatment, where sperm retrieval rate was 61%. Now, this is a combined retrospective analysis, and there are limitations because treatment was with a combination of SERMs as well as aromatase inhibitors, as well as aromatase inhibitors plus HCG. But there's no evidence of benefit from medical therapy, at least in our observational data in a large cohort of patients. Of note, the one randomized controlled trial of a small number of men with letrozole did suggest benefit of treatment. All men on letrozole had return of sperm to the ejaculate, 26 out of 26 men. I've got to say that's pretty remarkable. In my clinical experience, it's very rare to have sperm return to the ejaculate in men with non-obstructive azoospermia unless the sperm were there to start with and just missed on prior semen analyses. But again, they reported a marked difference between that and the placebo-treated patients, all of whom remained azoospermic. So I would argue that appropriately designed randomized controlled trials to look at pre-treatment of men before microTESE and non-obstructive azoospermia have not been done. The published data to date are confounded by a lack of control patients in most studies, and azoospermic men clearly need control evaluation because some of them can have rare sperm found on a repeat semen analysis. So data supporting the use of medications before surgical sperm retrieval are limited. I expect that most likely, although we don't have a formal report yet from the AUA, I suspect most likely this will be the statement that is made by the AUA regarding this clinical scenario and whether you should use SERMs or aromatase inhibitors. So, statement should be, patients should be informed of the limited data to support use of pharmacologic treatment prior to microTESE with assisted reproductive technology. Limited benefit. Interestingly, we have made an observation that although the baseline testosterone level does not really predict sperm retrieval, at least in Klinefelter patients, it is possible that the results of medical treatment may predict sperm retrieval. So here we see the men who had sperm found have a baseline testosterone level that is only 170. This is about 6 nanomoles per liter. The men with no sperm found had baseline testosterone levels of about 5.5 nanomoles per liter. After treatment, those men who responded, meaning whose testosterone levels on average went above 10 nanomoles per liter, were more likely to have sperm retrieved than the men who did not respond to that testosterone enhancing treatment. So again, our experience is that men with Klinefelter syndrome and low testosterone who respond to treatment with medical therapy are more likely to have sperm retrieved. I don't think that necessarily tells us that the medical treatment increased sperm production. It may just be that men with better testes are both more likely to have an increase in testosterone with treatment, and they are more likely to have sperm found on microTESE. In other words, the medical therapy is really just selecting out those men who had better testes to begin with. It's not clear that there's a causal relationship between that treatment and the ability to retrieve sperm. So how about FSH for men with idiopathic male infertility? So there's a documented role of FSH for men with hypogonadotropic hypogonadism, just like with HCG, and that includes men with Kallmann syndrome. Do men with idiopathic infertility, meaning normal FSH, did they benefit from FSH administration? A number of studies have looked at that, and I'll review that literature now. The usual treatment doses were about 150 international units per day for a 12-week or 3-month period. They both evaluated men who were attempting unassisted conception, as well as men who are in couples undergoing assisted reproductive technology treatments. A meta-analysis of 15 controlled trials with various FSH agents in the treatment of idiopathic infertility has been done and reported. The evidence of benefit for FSH treatment versus placebo exists. It improved sperm concentration, but not progressive sperm motility. Looking at unassisted trials, meaning attempts for unassisted conception, there are 389 men versus 308 controls. The odds ratio for benefit of FSH treatment was 4.5. For men who were treated with FSH prior to assisted reproductive technology, the benefit of treatment provided an odds ratio of 1.6. Again, fairly substantial evidence, or at least level 1 evidence, that benefit could exist with FSH treatment. Unfortunately, again, when we look at absolute pregnancy rates unassisted, this odds ratio of 4.5 really only reflects an 11% pregnancy rate with FSH treatment compared to a 2% pregnancy rate after control treatment. In assisted reproduction with FSH treatment, the pregnancy rate was 27% versus 20% for control treatment. This is just a summary of the odds ratio in terms of benefits of treatment. And again, when you look at these sort of studies, it's very important to look at events, meaning the number of pregnancies that occurred both in the control group as well as the FSH group. And again, numbers are relatively small in terms of the proportion of pregnancies that occur. So, level 1 evidence demonstrated benefit of FSH treatment with resulting improvement in pregnancy rates, including unassisted pregnancy rates as well as pregnancy rates after reproduction. But it's important to remember that the unassisted pregnancy rate was only 11%, and the absolute difference in pregnancy rates for those undergoing ART was only 6% after this 3 months of treatment for men. Now, others have looked at this in different ways to see if the 150 units per day is the best dose. One study looked at 50, 100, 200, 300 international units per day in 345 idiopathic infertility men. Unfortunately, they were unable to demonstrate a benefit of FSH treatment in this subgroup, and no superiority was seen for any of the treatment doses. So if you're going to use FSH, the most commonly used, meaning 150 international units per day for 12 weeks, makes the most sense. FSH treatment, therefore, may be discussed with male infertility patients, but the cost effectiveness of such a treatment may be relatively limited because, again, there's a relatively small increase in the proportion of pregnancies occurring. So, medical treatments that have a rationale for enhancing male fertility include the SERMs, aromatase inhibitors, gonadotropins, HCG, and FSH. The treatment of men with low serum testosterone is certainly rational. It makes sense to treat an abnormality in a male who has infertility and low testosterone, but the data really do not exist to document the benefit in this subgroup of patients. Certainly avoiding exogenous testosterone in men with infertility is critical, and it's also reasonable to treat low testosterone in men with infertility using SERMs, although again, the data documenting that benefit don't currently exist. It is rational and makes sense, and it's certainly something that I commonly do in managing my patients. For men with idiopathic infertility, data supporting treatment using SERMs and aromatase inhibitors is certainly evidence-based, but there are small benefits of these treatments, and the benefits are certainly far less than results that we expect for assisted reproduction. Similarly, treating men with idiopathic infertility using FSH injections is evidence-based, but the absolute benefits of such treatment are very small. The data for men with non-obstructive azoospermia, unfortunately, is much weaker. Most of the studies have been uncontrolled, and they have an unclear magnitude of benefit, with some observational studies suggesting no benefit whatsoever in that subset of patients. So now let me pause for a minute and talk a little bit about microTESE and the management of non-obstructive azoospermia. And I think all of us agree that non-obstructive azoospermia is one of the most severe forms of male infertility and can be very challenging. It is difficult and disruptive for patients and the couples who have this condition. It is challenging for us as we struggle to get rare sperm and help these couples to achieve a pregnancy. So the concept of microTESE is based on an observation that I made a number of years ago, that some areas of the testicle of men with non-obstructive azoospermia are physically different, and those physical differences can be recognized using an operating microscope. And the larger seminiferous tubules depicted here, these larger tubules actually translate into tubules with far more spermatogenic cells, tubules that are much more likely to have sperm than the smaller fine tubules that are much more likely to have the predominant pattern of Sertoli cell only that we see in most men with non-obstructive azoospermia. The surgical procedure itself is somewhat complex, and my trainees tell me that it is difficult to learn. It requires a large incision within the testis, which I don't feel to be of any concern in terms of the function of the testicle, but the process of dissection within testicular tissue needs to be detailed. It needs to be carefully done. And fortunately, it can be done by following the natural anatomy, the natural planes of the seminiferous tubules that follow or run in parallel to the intratesticular blood supply of the testis. So we look at higher level, we see that basically the vessels run parallel to the seminiferous tubules, so it's possible to dissect between the tubules close to these vessels, maintain the blood supply to the testicle, and still examine or dissect and examine large areas within the testicle. So a meta-analysis was done of sperm retrieval techniques. It involved about 1,900 patients in a variety of different studies, and it looked at only studies that had comparison between different techniques. It compared TESE or FNA mapping to conventional TESE with multiple biopsies, and it compared conventional TESE to microTESE. Basically, the summary is that conventional TESE doing biopsies is twofold better than doing a needle-based approach, and that microTESE is about 1.5-fold better than conventional TESE, meaning has a sperm retrieval rate that is better than conventional TESE. This is just an illustration schematically of the procedure of microTESE, where a wide incision is made in the tunica albuginea to allow exposure of large areas of the testicle. The testicle is actually open widely, which allows the natural architecture of the testicle to be examined. Manipulation with a finger behind the testicle is really critical to allow the best ability to dissect out the tissue and to examine different areas at high power. You can see how this dissection is done parallel to the seminiferous tubules and parallel to the brown blood vessels shown here, and individual foci of enlarged seminiferous tubules can then be identified, and only small bits of tissue need to be removed for sperm retrieval in these men. We have done microTESE in over 2,600 men at Weill Cornell. We typically do sperm retrieval together with IVF. That allows adequate time. We do the sperm retrieval often on the day before the female partner's egg retrieval. That allows time for processing of tissue. It also still allows us to inject fresh sperm, which we find, at least retrospectively, works better than frozen thawed sperm. Overall, 54% sperm retrieval rate seen for non-obstructive azoospermic men in first-time attempts at this procedure. Once sperm are retrieved, the fertilization rate per injected egg is 45%. The pregnancy rate, once sperm are seen in the operating room, that a chance that a woman will be pregnant with a fetal heartbeat on ultrasound 6 weeks later is 46%. Now, there are several important components of this procedure in our coordination with the IVF team. First of all, for all men, we recommend a repeat semen analysis on the day of planned TESE, because again, occasionally we will find sperm in the ejaculate, and we want to make sure that we're not operating on a man who doesn't absolutely require surgery. Secondly, sperm retrieval on the day before egg pickup allows sperm acquisition of motility, even though most men with non-obstructive azoospermia don't have motile sperm at the time of retrieval. Most of them acquire some at least twitching motility prior to injection. It also allows us to have the lab process those tissues and prepare for ICSI. The sperm search we do in the operating room is done with a simple phase contrast microscope. The results of that analysis by our embryologists allow us to stop dissection when adequate sperm are observed, meaning we believe we have enough for ICSI. If no sperm are seen in that initial evaluation in the operating room, then in-lab processing is done. The supernatant or fluid is separated from the precipitate or testicular tissue components by spinning at 1800 Gs. The precipitate is digested with 0.1% collagenase for an hour, and then further examined by a team in the lab using microdroplets. But unfortunately, if we don't see sperm in the operating room, less than 3% of men will have sperm found in the lab that can be used for ICSI. So again, the analysis in the operating room is very informative, and it helps to guide when we're done with the surgical procedure. Now, our experience suggests that the chance of finding sperm in non-obstructive azoospermia, because it is dependent on the single most advanced region of spermatogenesis, and of course finding it, is really independent of the usual parameters we use to evaluate men. It's independent of FSH, it's independent of testicular volume, because each of those reflect the overall function of the testicle, not the focus of most active sperm production in a dysfunctional testicle. These are the results comparing FSH to sperm retrieval rates. You can see on the far left, even with a low FSH, sperm retrieval rate is actually lower than what we typically see in men with markedly elevated FSH, including men with FSH of 60, 80, 100, and higher. So FSH does not predict sperm retrieval because it doesn't tell us about the best area of the testicle. Excuse me. Finding sperm is critically dependent on a detailed search. An initial opening of the testicle only finds sperm about 60% of the time. Deep dissection or contralateral dissection is required to find the remainder of the sperm. So the efficacy of the surgical procedure, the ability to search through many areas, which can take a number of hours, even with significant experience, is important. And of course, it is important to do that safely and maintain the blood supply to the testicle. Management of Klinefelter is sort of a classic example in non-obstructive azoospermia. For couples where the man has Klinefelter syndrome, sperm is the most limited resource. Up to 70% of men have sperm in the testis despite the lack of sperm in the ejaculate for men with this diagnosis. And although there's a low fertilization rate of eggs, even with ICSI, which means there's a limited number of embryos for transfer, making the most out of these sperm is critically important. So different from standard IVF where people will go to day 5, we often transfer before day 5. So we don't hold the embryos for biopsy for genetic analysis. That certainly limits the options for genetic testing, but day 3 transfer is critically important to optimal management of patients with Klinefelter syndrome. Fortunately, that's possible because men with Klinefelter syndrome have a very, very low risk, less than 1% risk of actually having a son or daughter with an extra X chromosome. So in terms of microTESE, microTESE continues to be the gold standard for surgical treatment of men with non-obstructive azoospermia. Sperm retrieval is certainly difficult to predict preoperatively. Effective sperm retrieval does clearly result in, depend on surgical technique in our experience. In operating room examination of retrieved samples helps to guide the procedure. And this is a tightly coordinated process to do sperm retrieval fresh together with IVF. All patients, we believe, should have a repeat semen specimen analyzed on the day of planned sperm retrieval surgery because we're able to cancel 5 or 10% of the planned surgeries, which again makes our sperm retrieval rate even more important because we've already eliminated a number of men where we use rare sperm in the ejaculate, even though they were found to be azoospermic on several cases before. So again, I would like to go ahead and thank the Saudi Andrology Group for the opportunity to present, and I'd be happy to answer questions or review cases.
Thank you very much, Prof. Schlegel. Now we'd like to move for our cases by Dr. Saad Abu Malha, please.
Sure. I will share my screen.
Sure.
Okay, is it clear now?
Yes.
Yes,
Okay.
go ahead.
Thank you, Prof, for your valuable presentation and very informative. We'll start with our two cases. The case number one, 34-year-old male referred to infertility clinic as a case of primary infertility with healthy wife, 27-year-old. They are married for 3 years and he is healthy with normal libido and sexual life. He is non-smoker with unremarkable past medical history, and he underwent appendectomy in the past with no drug history. He has normal secondary sexual characteristics with normal phallus and meatus, both testes showing the volume of 14 and 16 ml, with grade 2 left varicocele and grade 1 right varicocele. Testosterone was normal with a FSH of 10.7, and he has confirmed azoospermia in 2 semen analysis. Ultrasound has confirmed bilateral varicocele with reflux, and at the other hospital, FNA showed no sperm. So, Prof. Schlegel, what's your approach in such a case, please?
Sure. So this is a great case for discussion, management of varicocele in a man with non-obstructive azoospermia. So overall, the benefits of varicocele repair prior to attempted microTESE or attempted IVF with possible microTESE in men who have non-obstructive azoospermia is pretty small. We estimate that the chance of actually getting sperm to return to the ejaculate to be less than 10% in these patients. And our retrospective experience is that you don't increase sperm retrieval rates, although again, that potential 10% benefit shouldn't be ignored. Now, the difficulty with varicocele repair prior to treatment is you need at least 6 months after the varicocele repair to realize or obtain that benefit in terms of varicocele repair, varicocelectomy, increase in sperm production. So one of the more important factors is wife's age. And fortunately, this is a younger woman at age 27, and that is encouraging in terms of whether you can wait the period of time from varicocele repair to proceeding forward. It's also relevant that this patient has had a prior attempt at sperm retrieval with no sperm found and has a relatively low FSH, 10.7. FSH in normal men should be less than 7.6, but an FSH of 10.7 suggests that this man could have a degree of maturation arrest or hypospermatogenesis. So at least there's likely to be germ cells present that the varicocele repair could act on and enhance their ability to develop and become sperm. So for this type of couple, I tend to be more enthusiastic about recommending varicocele repair prior to another microTESE because they should have a higher chance of response than the average non-obstructive azoospermic patient. And secondly, you're somewhat back against the wall because you've already had a failure of attempted sperm retrieval. And because the wife is younger, you have time to allow that 6 months or more from varicocele repair to your next ICSI to go ahead and realize any benefit from varicocele repair. So of course, we leave these decisions up to patients, but this is a couple where I would encourage them to have varicocele repair prior to treatment.
Thank you, Prof. The second case, it's a very common case. It's 32-year-old medically free male with primary infertility, young and healthy wife, married for 5 years. He's healthy with normal libido. He has mild erectile dysfunction. He's a smoker, a remarkable past medical history with past surgical history of microTESE 18 months back with no sperm, and histopathology has shown maturation arrest, and he's not on any medication. He has normal secondary sexual characteristics with normal phallus and meatus, both testes around 12 ml with no varicocele, and both vas were palpable. His testosterone is 12, FSH of 9, LH of 10.2 with normal prolactin, estradiol of 126. His semen analysis is still azoospermic and a remarkable ultrasound. How do you approach this patient, Prof. Schlegel?
Sure. So as with all men with non-obstructive azoospermia, we would certainly also have gotten genetic analysis, karyotype and Y chromosome microdeletion analysis. Certainly men with AZFB deletions can have maturation arrest, but have almost zero chance of retrieving sperm. We don't know of any documented case where a man with a complete deletion of the entire AZFB region has actually had sperm that could be used with assisted reproduction. Of course, we also don't treat men with AZFA deletions, but they don't have maturation arrest in most cases. So maturation arrest is challenging, and the pattern of maturation arrest is important. With his relatively low FSH, I'm actually concerned that he likely has what we call diffuse maturation arrest, meaning every tubule with maturation arrest. And in that situation, it is extremely difficult to find a rare tubule that is larger than another with microTESE. And that's one of the potential limitations of microTESE. Even though only about 6% of men with non-obstructive azoospermia have that diffuse maturation arrest, it is an extremely difficult group of patients to treat. If men have a mixed pattern of Sertoli cell only and maturation arrest, it is quite possible that other foci with better sperm development or better germ cell development are present, and we could find that with a microTESE procedure. So certainly considering moving forward with microTESE and IVF is reasonable. But the prognosis can be extremely poor, particularly for those men with diffuse maturation arrest. We use an extended sperm preparation to try to find any rare sperm in the ejaculate, because any sperm in the ejaculate will be better than trying to do a surgical search and find rare sperm within the tissue itself. In our experience, it just doesn't work well. We are also working with cell sorting techniques. So much more sophisticated approaches to taking the billions of cells that can be obtained from a testicular biopsy and isolating the rare sperm that are within them. We have some suggestions that this can be feasibly done and will allow us to pick out some rare sperm that are present within that tissue, and then potentially use those sperm together with ICSI. We haven't applied that in actual treatments for patients and shown success, but we have seen, at least in some preliminary trials, that there's some opportunity to identify very rare sperm. So experimental approaches certainly are a potential. Maturation arrest is very difficult to treat. Being absolutely sure that this is azoospermia is critical before proceeding with surgery. And again, looking for Y chromosome microdeletions we feel is also important because that is not something that we have been able to, nor anyone else to our experience has been able to successfully treat.
Thank you, Prof.
Thank you, Saad. Thank you, Prof. Schlegel. Now we would like to move for a question from the audience. Dr. Abdelmajid, can you check the question, please?
Abdelmajid, unmute yourself. You are muted.
Yes. Thank you, Dr. Peter, for the wonderful presentation. I have until now 2 questions from the attendees. The first question from Dr. Abdulaziz Ba'adin. His question, do you approach men with high testosterone and FSH, those with possible partial androgen receptor insensitivity, any differently?
So men who have high testosterone and high FSH and typically high LH are at high risk of having partial androgen insensitivity. Unfortunately, we don't have good predictive factors, meaning we don't have, for example, an analysis of the androgen receptor that allows us to predict which of those men will have sperm available to retrieve. We do often find Sertoli cell only diffusely in those men, but unfortunately we don't know whether they can be successfully treated until we attempt to look within the testis. There is certainly some literature that suggests that if you use clomiphene citrate or even exogenous testosterone to sort of higher power or overpower the testicle with more testosterone, that you'll actually get enough testosterone to the androgen receptor to make it work better. We've certainly used clomiphene citrate in that setting, even though the testosterone is normal or high to begin with. I can't say that there is much proof that that makes a difference, but it certainly is a widely held concept and worth considering to give these patients clomiphene, even though their testosterone is normal or high to begin with.
Okay. The second question from Professor Dani Rabah, and he has a question of 2 parts. The first question, do you recommend conventional TESE before microTESE?
So when we looked back at what happened to our patients who had conventional TESE, we found that they had excessive scar formation from bleeding that occurred during those standard biopsies of the testicle. And therefore, we do not proceed with conventional TESE. We will proceed directly to microTESE. Why is microTESE any better than conventional TESE in terms of preventing scar tissue and preventing problems? Well, by having wide exposure of the tissues, you can control bleeding, and it is the bleeding after a biopsy that causes most of that scar. So by doing microTESE, you make a slightly larger incision, but actually you cause less damage to the testicle. You result in less bleeding inside the testicle. And again, that's the cause of most scar formation. So no, we do not do conventional TESE first. We do not routinely do biopsies first. The biopsies are obtained during the microTESE just to confirm what has been treated and rule out carcinoma in situ or intratubular germ cell neoplasia.
The other question, do you request testosterone level for men with normal count but teratoastenospermia or astenoteratospermia?
Yeah, so the best data on whether you're going to have abnormal hormone levels comes from analyzing whether men have low sperm counts or normal sperm counts. So for men who have infertility, if they have normal sperm concentration, most of the recommendations and guidelines are not to do hormonal therapy. I've got to say, if men have a significantly abnormal semen analysis, including, as you said, isolated asthenospermia or teratozoospermia, we'll look for any abnormality. So somewhat contrary to the guidelines that are written, I will commonly get hormone levels for those men because frankly, we don't have that many treatments that we can provide independent of hormone treatments or varicoceles or other specific identified abnormalities.
Okay, the third question from Dr. Shihab. His question: in men with severe OAT and no varicocele, with normal or low normal testosterone, what would be your therapeutic pathway?
I'm sorry, with severe OAT and
no varicocele, with normal or low normal testosterone, what would be your therapeutic pathway?
Okay. So if men have testosterone less than 10 nanomoles per liter, I will treat them to enhance their internal testosterone production. If men have a normal testosterone, anything over 10 nanomoles per liter, I generally will not treat. Now, you could look at those data on idiopathic infertility and say, perhaps SERMs have some benefit there, perhaps aromatase inhibitors, perhaps FSH has some benefit. Again, I expect the benefit is relatively small, and certainly the chance of natural pregnancy is extremely small from that treatment alone. But I generally do not treat for men who have a technically normal, even though it's a low normal testosterone.
And there is a question from Dr. Mishari Al-Zahrani. He's asking about the hormonal induction before second microTESE or testicular optimization, I mean, before the second microTESE.
So for men who have a low testosterone and non-obstructive azoospermia, either before a first procedure or a second procedure, if the testosterone is low, we will treat it. If the testosterone is normal, we do not. So when we look at men who have a failed TESE or microTESE and then have sperm found in a second procedure, there are two variables. One is whether they get medical therapy, and a number of studies have said if you give medical therapy before that second surgery, you're more likely to succeed. But what they're missing is whether men just repeat the microTESE with a more detailed search. And our view is that actually the difference between a first microTESE and a second is usually more the extent of the search, and there's no clear defined benefit of medical therapy, even though there are dozens of publications that have that comparison and suggest some benefit. Why do they demonstrate or suggest a benefit? Because they were uncontrolled. They did not repeat the microTESE without medical therapy. Now again, if there's an abnormality like a low testosterone level, it only makes sense to treat that before you reoperate on someone. But in the absence of a low testosterone, in other words, for men who have normal testosterone going into a second TESE procedure, I think patients like the concept that something different is being done, but the evidence to support that, I think, is lacking. A more careful surgical procedure, a more careful search is probably what's most critically important. It is easy to miss an area of sperm production within the testicle, particularly if that search or dissection within the tissue is not complete.
Okay.
Thank you, Abdulmajid. I think Saad, he has one question. You have raised hand. Saad?
Yes. Yeah, thank you. Prof, we receive a very common question from patients, especially those with post-surgical sperm retrieval with Sertoli cell only. Usually they mention that in semen analysis they have round cells or spermatocytes. Is it of any clinical meaning?
Well, unfortunately, it is difficult to identify cells, including spermatocytes within semen. If special stains were done to confirm those spermatocytes were not macrophages or other white blood cells, within the semen, then it certainly would be encouraging to consider a repeat surgery to find those areas with germ cells that are present. Unfortunately, the identification of germ cells within semen specimens is really more of a research approach than something that's standardly available clinically. It is extremely difficult in the average or standard semen analysis to really be sure that cells are germ cells and not just leukocytes of another form or macrophages.
Abdul Malik.
Yes, sir.
If you allow me, Prof. Schlegel, thank you. Very interesting presentation. I have benefited a lot actually because it just gives you where do we stand now. So just to tell you what's going on in Saudi Arabia, you know that we don't have sperm donation here. So, you know, when you do a microTESE, I just want to have one comment, Prof. Schlegel. I would like to see your face because I would love to see it more brighter. It's dark a little bit.
Sorry about that. My background is too light.
That's much better.
Yeah.
That's much, just you know, just to see your shining face. So what happens? You know, you do a microTESE regardless of the histopathology, Sertoli cell, maturation rest, late, early, whatever. So what happens? You know, it's like you got married to that patient. He will keep coming to you every week in the clinic. What's next? What's next? And you've seen the type of Saudi men that you have. I don't blame them because we don't have sperm donation, and you know they're stuck. His wife loves him and she wants to stay with him, and he wants to do a favor. So sometimes, you know, a subgroup of those patients, although they've been for sure azoospermic before the microTESE, they start to have here and there, you know, some ejaculate sperms post-wash. And I've seen the last one was 2 weeks ago, actually, after 3 microTESE by experts, he landed in my clinic. I did just a simple semen analysis, he has ejaculate sperms. And I confirmed that again by another semen analysis. So maybe they got him during his worst time of the year, maybe when he did the microTESE, maybe, you know, he recovered some of his spermatogenesis. I don't know what happens. Now, this is just a comment, but see, now we know that the Japanese now are doing the elongating spermatid. And what they do here, I've seen a video of that, you know, and they published about 30 babies out of round spermatid or elongating spermatid injection. So, and what I mean by that, you know, I go with the lab myself and see the sperms. So if there's a sperm, there's no doubt. But sometimes, you know, you get a fight, you and the embryologist, where you start to see the tail, the head is little big, and you know the embryologist is not calling it a sperm, but you're calling it and then you get the confusion. So do you think it's wise to inject those? I don't know what you call it. Is it elongating spermatid, or is it an immature spermiated sperm that still has a residual of either a cytoplasm or a big head? So do you think it's wise to inject that? Although they struggle sometimes with the needle because, you know, the regular needle is small where the head does not adopt there. But however, sometimes they use even a biopsy needle that can adopt that big head. So do you think it's wise to inject with those elongating, quote unquote, immature sperms?
So I think it is important to remember that none of the sperm that we get from men with non-obstructive azoospermia, none of those testicular sperm have normal morphology.
Right.
Our internal analysis is that the actual appearance of those sperm really doesn't predict how well they're going to work, meaning fertilization rate and pregnancy rate is not well predicted by the appearance of sperm. Okay. I often have my andrologists make a very pained expression when they have sperm that look very abnormal from the testes of men with non-obstructive azoospermia, and I encourage them strongly to use those sperm. And our results suggest that you can still get pregnancies even though the sperm are markedly abnormal from a morphologic standpoint. Now, larger headed sperm are another question. That, if it is globozoospermia, for example, that's a completely different condition to treat. But If the sperm can be injected, we recommend injection be done. And again, most couples will want that. It is very frustrating for them to know that sperm were present and not used. We refer to testicular sperm, but frankly, many of the cases where we actually do injections, these are elongating spermatids. They have not finished their maturation. They do not have full-length tails, and therefore, they are not fully developed testicular sperm. The round spermatid data are a little more interesting to consider. And certainly other experts in Japan don't believe that what has been reported is actually success. They feel that most of the patients who've been successfully treated are those who had testicular sperm to begin with. But again, we don't know the limits of what we can use in terms of ICSI and injection into eggs and still get pregnancies despite having severe sperm abnormalities. And we push very strongly. And fortunately, Dr. Palermo at our site is willing to go ahead and perform ICSI on cases that I think many other laboratories would say the sperm are just not good enough to use, because we still get pregnancies in those cases. Now, getting back to the concept of having rare sperm in the ejaculate, we see rare sperm in the ejaculate sometimes, not all the time, in men with maturation arrest. We make every effort to avoid further surgery in those situations, because even if you have frozen eggs that you use with those rare sperm, if you are persistent enough, you will eventually be able to achieve a pregnancy. And we think that's the best approach, not doing more surgery to try and get more sperm, because in maturation arrest, even with rare sperm in the ejaculate, you often can't find sperm with surgery, even though you have occasional sperm in the ejaculate. I hope that answer was clear.
Yes, the answer is clear, and you made my day, because that's the fight I used to have with my embryologists, telling them, please do not apply Kruger criteria on testicular sperms. That's ejaculate. They want the acrosome to be 30% of the head. This does not apply to testicular sperm. This, by definition, they are abnormal sperm to start with. So thank you for confirming my, Go ahead.
Encourage the andrologist to look at Dr. Palermo's description of testicular sperm from men with non-obstructive azoospermia. It is zero normal morphology in all cases.
Is that a paper that we can reach? Because I need to show them an evidence.
Yeah, I think that was actually published as late as 2010. It's, I think, management of azoospermia, or ICSI for azoospermia. Let me see if I can find that for you. But yeah. That's been published. We have presented those data on morphology and specific subsets of morphology at ASRM, but we hope to get that into a publication in the next year or so.
I wish to see such a paper. So that's great. I don't know if the chairman allows me because of time constraint. Just one question, Prof. Schlegel, regarding those who have idiopathic severe oligospermia. So he comes to you, he has 3 millions, he does not have a clinical varicocele, and he's not a smoker, he's not obese, even there is no lifestyle modification. So in those subset of patients, they have disproportionately normal FSH. So the FSH is 4, and we know this guy is most likely and a maturation arrest, and out of that maturation arrest, he got those, let's say, 3 millions. So now, I just published a paper on this 3 months ago where we were comparing the FSH. So do you think there's a point of challenge them with an FSH injection and see over 3 months? Because whatever the reason is, that they have a lazy pituitary because it's not reacting properly. So especially now with having from Ferring, we have now the Menopure, which is sub-Q. So patient doesn't have to go a local dispensary to be injected. Now we have a sub-Q. So do you think there's a point of giving him an FSH for 3 months?
I think that that is an option in terms of management. It's an option to discuss. The chance that that is going to fix his condition is relatively low. His FSH is low because his body is sensing so many areas of germ cells within the testicle. Those germ cells are not all completing their development to be fully formed sperm, but it's sensing it. The problem is within the testicle, probably not the FSH itself. Is a trial of FSH reasonable? Yes. Is it likely to succeed? Probably not, but it's certainly an option.
Okay.
One thing we strongly avoid in those men with severe oligospermia is we avoid doing TESE unless there are severe abnormalities of sperm DNA fragmentation that are seen, because you often get worse sperm from the testicle than you have in the ejaculate. Sorry.
Absolutely.
Okay.
Unless they have recurrent ICSI failures with the high DNA fragmentation. That's what the evidence is.
Correct.
Yeah.
Okay, we are concluding our session now. I would like to thank Prof. Schlegel for his presentation and valuable comments. Thanks also to Prof. Naif Al-Haddal, the Saudi Andrology Group Chairman, and our moderators, Dr. Saad Abu Malha and Abdul Majid Thbeiti, with a special thanks to Ferring Company for sponsoring this webinar. Thank you, everybody.
Thank you so
Hoping
much.
to see Prof. Schlegel in Riyadh very soon.
Thank you. Look forward to being back.
Thank you so much, sir.
Thank you.
Thank you.
Thanks. Have a good night. Bye-bye.
Okay.